Thank you so much, Dr. Henke, for joining us today.
Hi.
Would you mind introducing yourself briefly for our viewers before we get into it?
Sure. Name is Peter Henke, vascular surgeon, section head at University of Michigan.
Perfect. Awesome. So would you mind taking me back to where your interest in medicine began?
Yeah. So I think probably in high school, interested in, kind of had a science interest, and then ended up starting my undergraduate career at University of Wisconsin-Madison. And probably by about midway through the first semester, decided on biochemistry as a major, and really debated between kind of going the PhD route or pure science route versus medicine. And ultimately took the pre-medicine and biochemistry classes. And this was the days before actually they had PCR, which is used in everything from crime to science every day now. But so it was a while back, and kind of probably just prior to senior year, decided on the medicine route versus pure science route, and in part because I wanted to, in medicine with an MD, you can do research as much as a PhD, and you also have, of course, the ability to interface with patients, clinical work, and that type of thing. So I thought more options there, and if it just fit me a little bit better. But that's how I ended up toward the MD versus pure science route.
Interesting. Did you have exposure to research yourself?
I did.
As an undergraduate?
Yeah, a little bit. Worked in a lab junior, senior year, and that was a pure PhD science lab. Worked with a postdoc. Had a good experience. No publications resulted, but nonetheless, I got along with them well. It was interesting. The one they did assign like just kind of randomly career advisors. And this person was pretty uninterested in advising people unless they were going to do a PhD. So again, it turned me off a little bit from that, just with that interaction. But yeah, so knew I had some interest in science, even though a lot what we did didn't totally work out, but still had kind of that bug, to investigate things at a more basic translational level. But then, dove headfirst into medical school once I was accepted.
And so now, compared to back then, would you say that medicine, science, and research is what exactly you thought it was?
I think more or less, yeah. I mean, I think at least a lot of the surgeon scientists I know work a little more in the translational than in the basic hardcore molecular arena, but that's not 100%. Certainly things have evolved a lot since the 90s when I was kind of like late 80s, 90s was when I was in undergrad and medical school. So certainly it's so much more sophisticated now. I think that as a clinician scientist, it is a challenge to remain state of the art. And so that's something you have to work on. But importantly, I think that's where your collaborators are so important. So like anything in medicine, same in science, it's really a team effort. And I think the team science, team effort, way of doing things is much more common and much more accepted. It used to be in the old days, kind of single investigator, single lab, and more of a siloed thing. And I think now it's much more of a multi-specialty, multi-collaborator effort. Just because if you look at, especially real high impact works, in let's say vascular biology, multiple authors, sometimes multiple labs, and the techniques are so sophisticated that you have to have that broad expertise.
The collaboration.
Yeah.
And so you mentioned basic versus translational for viewers who aren't really aware of like the science lingo. Do you mind elaborating on what the different fields are?
Great question. So basic is kind of investigating a disease state, and I'll give my example. So my research interest has been in venous thrombosis, which is basically a clot in the deep veins of the leg. People probably heard of commercials for certain blood thinners that are, someone who's had a DVT blood clot is how they term it in the commercials. So it's a common problem. It can be fatal. There's not a lot of surgeries for it, although there are some catheter-based techniques to get rid of the clot, but typically it's treated medically. What do I mean by treated medically? It's treated with anticoagulation, elevation, compression, that type of thing. And so with that, the basic part of that is just investigating, usually in animal models. So we have a mouse model. There's other models as well. What are the cells involved? What are the factors involved in this type of thing? And a lot is known, but a fair bit isn't known, especially with some of the abilities to get into the cellular specific RNA transcripts, for example, called transcriptomics, just to define really what's going on, much more in detail than they could do 10 years ago. So that's kind of the basic science part of it. Translational science is looking at, well, what have we identified as a pathway that could potentially have a pharmacologic agent or something that then you could modify the response to get a better outcome. So give another example. So one of the things after the vein is in contact with the clot, the vein wall gets inflamed, so it gets irritated, so to speak, and you have a injury response, which is scar tissue. And so looking at the pathways that drive that, and then looking at potentially an agent that could target that scarring to reduce it, that's a goal with translational work, at least in my lab.
So translational comes after basic is done normally?
Yes, okay. That's right. Perfect. That's right.
Wonderful. Now, back to your journey. So, after college comes medical school. Talk to me about, the decision to apply to medical school, where you went to school, and what medical school was like for you.
Yeah. So, again, everything was paper, applications and typewritten. I don't know if your audience knows what a typewriter is. I'm kidding, but, and so it was quite a while ago. So I applied to about, I think, 5 medical schools. I knew I kind of wanted to go to Wisconsin just because I lived in Madison. It has a good, it's a good medical school. Applied to a couple others. I think I got in 2 others, denied in 2, and then ultimately decided on Madison, which I was happy with. I wasn't living at home. I was living downtown in the area. And so then went into it. And back then the medical schools were a little more 2 years and 2 years. And what I mean by that is 2 years kind of initially it was physiology, second year was kind of pathology, and then third year was your first clerkships where you rotate through all the specialties. Fourth year is where you kind of specialize and take certain rotations that may be specialty specific in what you're going in. So did that and had I think a good experience. Was able to get good enough grades, and then they, you have your boards, which are 1, 2, and 3. Back then, step 1 was between years 2 and 3. Mm-hmm. I know it's a little more varied nowadays. And then basically at that point, so I think a key part of the medical school for me was I initially took surgery first as a rotation. It's an 8-week block because I didn't want to do it. I thought, well, it's a hard rotation. Let's get it out of the way. I was thinking more neurosciences. My dad was a neurologist. And so I thought, well, maybe that'd be what I want to do. But I really liked it. I mean, I just, I like the pace. I like the technical aspects, the patient care, the fact that, the surgeons were doing something and seeing a result, and there's, as probably get into, with surgery, there's anything you do has consequences, hopefully mostly good consequences, but not always. And so kind of really thought, man, this is great. And then my second rotation was in family practice. And they were nice people, but I was just like, it was mainly outpatient care and work. And I just didn't jive with that. My third rotation was 2 months of internal medicine. And again, just wasn't for me and my personality. So then went on, started the third year, second half, was 2 weeks of anesthesia and 2 weeks of, you could take a selective, what we call it. And so it could be orthopedics, urology, or vascular. So I took vascular surgery as a 2-week elective. And again, at that point, man, this is great. Like, even though it was like, 5:30, 6 in the morning till 8 at night, I really liked being there. I was lucky a little bit. I was the only student with the group, so kind of had a little more autonomy for notes and that type of thing. So like that. And then at Madison, to get kind of the chairman's letter, you had to rotate on their service, which in Madison had still does, a very strong transplant group. And so they the chair was a pioneer in transplant surgery. He was initially at UCSF, California, and then became chair at Madison. So you rotated through this service, and a lot of patients and students, and to get your chair's letter. And so I was debating at that point, general surgery, maybe transplant, maybe vascular. So did 2 externships. So I went outside of Madison, went to University of Louisville, in part because they had a big trauma hospital there. And Madison at that point was not even a level 1 trauma center. They are now. So I did a 4-week rotation in Louisville, every other night call, but again, loved it. And I was debating, and sorry, I kind of went ahead, but surgery versus ER medicine. Mm-hmm. So then I did a away rotation at Henke County, which is in Minneapolis, a really good ER program. I really like that, but for me, it was a kind of more of an issue of, number one, I'm not quite so much a pediatric person, so I didn't want to have a practice dealing with kids. Secondly, I like the ER is a lot of variety, which can be appealing, and it's shift work, so you're on or you're off. As I went through both of those early 4th-year rotations, I found I liked the potential for continuity, long-term patient relationship, a little bit better. Mm-hmm. Also, at that point, I was thinking, well, general surgery, and so at the end or mid part of 4th year is when you kind of send out your applications, and interviewed at, I think, I don't know, 8, 9, 10 places, something like that. I forget exactly the number. Kind of staying in the Midwest is where, at that point of my 4th year, got married, and so where we wanted to end up, was generally in the Midwest area. And so went through the application process and interviews, and ultimately matched at Louisville, which is where I wanted to go. And again, kind of, one of the themes with me is like, I was never a pre-planned person, so that I knew I was going to be a vascular surgeon at age 10, and had this whole path. I think most people, they don't have a straight linear path. It's up and down and figuring things out. And so matched at Louisville because they had the option to do research in the lab, but it wasn't mandatory. So if you matched a place like Pittsburgh or Michigan for that matter, or Northwestern or Stanford, most of those programs still have a mandatory 2 years in research. Mm-hmm. Now, in retrospect, I ended up, as I went through my residency, wanting to decided kind of around early 3rd year, vascular is for me, and I'll get into the reason for that in a minute. And I was able to do a research year. So that was helpful, because then that was key for then matching in fellowship. Got involved with vascular surgery. Again, starting out as an intern, you're pretty undifferentiated general surgery. And as an intern, you see, kind of take care of the patients on vascular who have amputations or failed bypasses, or just, they're sometimes challenging patient population because of their illnesses that coexist with vascular disease. Excuse me. And so, but got involved with some chart review research with a person who ultimately became my mentor there. And back then, again, there was no electronic medical records. It was all, paper charts. And so helped do some data review as well as arteriogram images, which again, weren't digital. They're all like hard copy films. And helped another resident who was working with, again, this mentor ultimately, who became, and got a couple of publications out of it. So not first author, but middle author. And also just reviewing the topic is, wow, this was looking at patients who had what are called femoral distal bypasses. That means using a vein from your groin to below the knee artery to salvage a limb, basically, to improve blood flow in someone who has long segment blockages in their arteries. And so from that research found like, wow, the outcomes are really quite good. I like this. And then kind of as you're a 3rd-year resident, you're getting in the operating room a lot more. So you're able to, see and do, in many cases, parts of the case at least. And it's like, yeah, I like vascular surgery. And so at that point, I was able to get into my mentor's lab, and then had finally an experience where a lot of things worked out. And so what does that mean? Well, you get the projects done, you get papers out of it, and then you present those papers too, which is just part of academic medicine. So had a real good experience with that. then as a fourth year resident, and again, they still have this pathway where you're general surgery trained, but then you do a fellowship afterwards. There's also the pathway of where you, as a medical student, you can go right into vascular surgery, much like orthopedics, plastics, ophthalmology, kind of this, just surgery specialties. So interviewed around at mainly academic places, knowing at that point I wanted to do academics and a lab experience. And so ultimately was fortunate enough to match here, which is where I wanted to go. And then back then the fellowships were 1 year research and 1 year clinical. So had another fortunately good lab experience with actually my former boss here and mentor. And then the second year is clinical. And so did that. And just by happenstance, a couple faculty had left here. And so they kind of offered me the job between first and second year, as long as I did okay clinically and could operate. And so then was able to kind of get a little bit of a leap ahead, so to speak, in terms of getting a lab started and then starting my career here. And so that's long-winded way of my background.
Wow. And so how would you say that wealth of research experience benefits your clinical decision-making as a surgeon?
I think so like the basic science aspect, you're not really applying day to day. I think the mode of thinking, quote, scientifically or scientific method, is translatable in the sense of how you review and interpret clinical studies. Mm-hmm. So much more of medicine now is relatively evidence-based. I mean, it still has a fairly long way to go. And what evidence-based means is, kind of a trial setup where, let's say, therapy A is compared with therapy B. They're compared head-to-head in a randomized, blinded fashion typically. And then you'll find maybe therapy B is better than therapy A. And there's a lot of statistics, of course, that go into making that conclusion, but allows you to kind of think a little more critically. If you have that research experience, it's a little bit different mode of thinking with regards to making sure you have controls, making sure the groups are relatively equal, blinded assessments, and these type of things. So I think that's on a day-to-day level, that's where it comes in most handy. Mm-hmm. Again, you're not going to be really thinking of a cell process when you're seeing a patient, but mm-hmm. but again, it's all a continuum.
Right. And do you ever see like moments where something in the lab or something in the clinical side translates into patient care, or something vice versa?
Yeah, I think we do. For example, in the lab, again, getting it back a little bit to my research area, again, this vein wall injury that occurs after a clot's been in contact with the vein wall is called post-thrombotic syndrome. Mm-hmm. And so we've done, with a collaborator actually from Boston, have done some work looking at, the more rapidly you can clear that thrombus within a certain time frame, you get a benefit, and if it gets beyond that time frame of clearing the clot, it's not a benefit. And so that can help inform patients who come in with a what we call a large DVT. That means mm-hmm. a whole vein in, let's say, the right or left leg is clotted. And so certain patients may be or maybe better served by clearing that clot with an aggressive catheter-based suction method, basically. Others, they resolve it on their own, and you don't need to, and they wouldn't benefit from that. So there are some correlative mouse model studies that highlight kind of that time frame, as well as getting into some of the analysis of the tissue responses, the vein wall responses that you can't get in humans, because with venous thrombosis in humans, you don't take out the vein. I mean, you don't take out the deep vein anyway. Mm-hmm. And you don't really get access to specimens. Whereas arterial surgery, because you operate on the arteries to do a bypass or an endarterectomy, endarterectomy just means clearing out the plaque and patching it open. You get a lot of tissue samples. So there's more ability to kind of directly look at artery samples than there is venous samples. So to answer your question, that's kind of going back between the bench and the bedside mm-hmm. and back again.
Interesting. And so for people who aren't really familiar with the pathophysiology of how you get a thrombus in your vein, like what are the impacts of that, and how can that sort of affect your health? Is this sort of like an immediately life-threatening condition?
Yeah. So we know kind of the risk factors for what's called DVT, deep vein thrombosis. Certainly, it's a disease of age, but it affects a younger group in 40s to 50s and beyond compared to atherosclerosis, which is generally 60s, 70s, and 80s. There are certain genetic factor abnormalities that predispose people to clotting. Family history is a strong factor of that. Obesity to some degree, immobility, patients who are in the hospital who may have had an infection, they're at higher risk of it. So we know, again, kind of the risk factors. In terms of the life-threatening, so there's life-threatening and then morbidity aspects. So life-threatening is if that clot breaks off, goes through the cava, through the heart to the lungs, called a pulmonary embolism, and that can be fatal, at least 10 to 15% of people. The more common thing is what I mentioned a minute ago, is where the clot resolves, but it causes a vein scarring, and then you get leg swelling, pain. In a small percentage, but significant number of patients get what's called ulceration. So you get this wound that doesn't heal around the inside of the ankle, and it's really bothersome for people. And so that's kind of the long and short of what it can cause death, but it really can cause morbidity.
And so what are some of the most common surgical procedures you perform as a vascular surgeon in terms of treating these sorts of varied conditions?
Yep. So even though I kind of research in the venous arena, so to speak, I tend to work in the artery side of things. And so vascular surgeons work pretty much throughout the body. And so in the legs, we'll do either endovascular, meaning through a catheter-based approach to balloon open an artery and stent it, or we'll do a bypass to take a person's own vein and use that as a new artery, so to speak, to bypass a long segment blockage. We do amputations for patients who have exhausted all other options to try to save their limb. In the abdomen, we work in the aorta, sometimes bypassing vessels that feed the intestines or the kidneys, and they can also be treated sometimes with angioplasty and stenting. We fix aneurysms, which are a dilation of the artery that can get so thin they can rupture and kill a person. And so those are treated either with fixing it from the inside out with a stent graft. You can imagine a ballooned out vessel with a pipe that's inserted. I mean, that's very simplistically put. That basically excludes the pressure on it. Or you can resect that aneurysm and sew a graft in. In the chest area, there's aneurysms that start within what's called the descending thoracic aorta. We work in that area. In the neck, patients who have blockages or narrowings in their carotid artery that could cause stroke, we work in that area and either take out the plaque and again patch open the artery, or they can be stented as well. So it's really a wide variety. Two last areas. One is the superficial vein system, which if you've seen people with varicosities, kind of the bulging veins on the leg, that's an area that we remove those veins, or they can be what's called sclerosed, kind of cause them to involute. And then lastly is patients who have kidney failure and need dialysis access. So that involves basically hooking a vein to an artery, generally in the arm. And that's a common procedure we do as well. So vascular surgery has a lot of variety of where we do our procedures and what we do. The third part of it that I always mention to students who may be interested is, so you have open surgery, you have endovascular, and then another part that I like too is vascular medicine. So that's where you may be seeing a patient who has risk factors for, again, typically atherosclerotic disease, what we call peripheral arterial disease. Patients with heart disease is called coronary artery disease. Peripheral artery disease is more in the legs. And so most of those patients don't need a procedure, actually. They just need to be on the right medicines to decrease the chance of them progressing. One of the big things, of course, that is hardest sometimes to do, but is important, is getting the patient to stop smoking tobacco. And so we rely on some specialists to help keep on those patients to try to stop, but that's key.
So this is more preventative sort of work.
Yeah. So vascular surgery also is not just doing the thing after they have a problem, but trying to prevent it too. That's a big part of our clinic part of the practice.
Would you say that that's different to other surgical subspecialties that are sort of intervening as sort of like a last resort?
Yes. I think vascular, is a little, it encompasses that preventative medicine aspect a little more than, let's say, a general surgeon who deals with patients who have cholecystitis or colon cancer or a thyroid cancer, something like that, where they're seeing a patient, they're taking care of the oftentimes cancer, let's say an obstruction or hernia too, but they're not really doing anything. It's not within the practice to do anything to prevent it. I mean, again, for hernia surgery, if they have a hernia, they can recommend certain things to decrease the symptomatology of the hernia, but not so much to prevent it.
Interesting. And so would you say that vascular surgery, the range of procedures that you're doing, it's really like quite broad in terms of urgency?
Yes, another good area that I talk with students about. So one thing with vascular surgery that if you're considering that, is that you have to be a person who doesn't mind being called at moment's notice for a emergent problem. So some people like to maybe do big procedures, but in a very controlled, thought out fashion. And it's not that we're not thinking out things, but you may be called to an operating room where another surgeon has gotten into trouble, let's say caused an injury to a deep vein in the pelvis and they have to be fixed because otherwise they'll bleed out. So you have to be a person who's going from 0 to 100, sometimes not every day, but usually once a week at least, depending on your practice setup. So I'd say with vascular surgery, about 30% of the cases are urgencies or emergencies. Maybe 5% are true emergencies. But the rest are urgencies where you may see a patient in clinic or the emergency room and say, all right, we got to treat you within the next 24 or 48 or 72 hours. And so that also is, you have to be very flexible in your schedule. Vascular surgeons generally know this going into it, but I think sometimes for students and even junior general surgery residents, they don't always realize that. And it's really important too, because it's just the name of the game. It's the name of the disease process. It can be exciting. It can be fatiguing. If you get a number of emergencies overnight, that's fatiguing. Right. And I don't want to sugarcoat that, because that's part of it's just the way the disease process is.
Interesting. So this is a good transition more into the lifestyle of being a surgeon. What does your day-to-day life look like from sort of, when you started as an attending and, over the course of your career?
Yeah. So certainly during training, residency, and fellowship, it's a lot of hours. There's hours that are controlled and restricted now. So the lifestyle is better than it had been 20, 30 years ago. But as an attending, it's pretty darn good overall. Because generally, if you're in private practice or if you're in academic practice, most of the time you're going to be in a reasonably sized group. So your call schedule, like for us, is about maybe 6 days a month, 24-hour shifts. Some of those are very quiet, where maybe you see a couple consults, but nothing emergent. Other ones, you're operating all day, and so the call schedule is pretty reasonable overall. In terms of day-to-day, any given week for me may be sometimes operating Monday, Tuesday, Wednesday, Friday, sometimes maybe once a week. It just depends on the schedule. I think in academics, compared to private practice, you have a bit more variety in what you do day to day. So teaching is an integral part of academic surgery or academic medicine across the board. So students and residents are almost always with us in clinic or in cases. And so our teaching, rather than being, in a classroom lecturing, it's seeing the patient, presenting discussing the patient's issue, talking about the disease process, and then coming up with a plan. So that's a typical clinic, scenario. In the operating room, students and residents are there. With the residents and fellows, we're helping them through the case and guiding it. With the students, they're helping assist, and I'm asking them questions, throughout the case, depending on, unless it's a tough part of the case. But so asking, the anatomy, pathophysiology, disease process, and then many times they may not know the answer, then we just talk about it and give them, the answer, especially if they're just starting on the rotation. So that's OR clinic, and then lab, typically lab meetings on Thursday. My lab runs pretty autonomously with I have kind of two main kind of a lab manager, animal surgeon, and then a kind of a molecular cellular tech person who helps things. And we have students and residents and sometimes postdocs who kind of head up projects throughout the lab. So the lab takes up a bit of time. And then, ultimately, many students who go into medicine may go on to leadership positions within the academic medical center or a hospital if they're in a more private practice setting. So for me, administration takes up probably about 15% of the time. Some of that is like rewarding activity with, helping your faculty overcome some type of small or bigger obstacles, promoting their careers, their science, and their practice. And sometimes it's dealing with human resources issues like people, personalities, that can be a little more challenging. Mm-hmm. So, but that's a little more toward the mid to later part of your career where you're more in the leadership part. When you're starting out, you're more focusing on, getting your sea legs, so to speak, and comfort level, getting your lab set up if you're doing research focus. And something I didn't mention, a fair number of academic surgeons do clinical and health services research, which is another big area to investigate. Some do biomedical engineering, more device design. Some do education. So again, with academic medicine, academic surgery, there's a lot of opportunities to do that. And I think, getting back to career choice and day to day, if you choose academic medicine, you again have to kind of be a person who likes a lot of balls in the air at the same time. Mm-hmm. And that can be a fun part. It can be a challenging part. And again, if you would have asked me at the beginning of residency, did I want to do academics? I would have said, maybe not sure. So I kind of through that, like I've already gone over, through that process of research and getting into the lab, then that kind of said, yeah, I really like this. Make one other mention of that just because I think it's relevant for people as they go through. Some might say, well, if you're in academic medicine or academic surgery, you're not really doing the case or you're not throwing the stitches or, and so that didn't really bother me, but I thought, I wonder if I will like that or not. But really, when you're an attending surgeon, you're as involved in the case as much as the person who's throwing the stitches or doing the cutting or the cauterizing and that type of thing. So I've never found that to be, I find it much, or at least as rewarding to teach the case as to do it. And so, so that's another thing that as a medical student, as you're considering, and as a resident, do I like the teaching or not? My hands on everything compared to someone who's like, you're going to teach someone else to do it. And it's individual, what they decide.
Perfect. For a student who is considering medicine as a career choice, what is one piece of advice that you would give them?
I think, make sure it's right for you. I think it's, everyone's stressed and you have to good grades. I would say that, but persistence. Many people do a year between their undergrad and their medical school. With that, I'd seek out an experience where, number one, you like it, what you're doing. Some do labs, some do other volunteer work, some do teaching. EMT is a common thing that emergency medical technician, that's a pretty common thing that people do. But I'd say to have as well-rounded an application as you can. It is competitive now. I mean, it always was, but it's definitely not easy. But I would say for the students, several of the students have gone through the lab recently, and it's not due to the fact they were in my lab, but it didn't hurt, at least in terms of their application, and they've then been able to get into medical school. So I think nowadays probably you have to take that extra year. It's pretty rare for someone to go through, even if they're 4.0 or whatever the top grade average and the highest MCAT score. You can do that, but it seems like nowadays you probably have to do a little bit extra experience. And at least at Michigan, I'd say that it's much more the exception than the rule that they go straight through. So most of the students who ask them, what did you do? What have you done previously? And they often have very broad experiences. So in that time, you might say, oh, geez, I don't want to spend a year, but a lot of people get a lot out of that, and you have a lot of your life to do medicine, in the, as your career. So I'd say that piece of advice that in my day wasn't such an issue, but I think it's realistic, or it's just a reality now.
Mm-hmm. Perfect. Thank you so much. Mm-hmm. So I'll sort of get into some more fun, interesting questions. If you could change one thing about the anatomy of the human body, or the vasculature of the human body, to make your job as a vascular surgeon easier, what would you change?
I'd say, like in a fantasy state, I'd say if you could have detachable intestines and organs where you could take them out, you'd see all the vascular structures that you need to intervene on, and then put it back in. Practically, the less obesity, the better. Because at least for open surgery, that is a challenge. That, again, when I started as a resident, most vascular disease patients were skinny thin smokers who had high blood pressure. Now they're sometimes morbidly obese diabetics who have vascular disease. And just the technical aspects of getting to the structures we have to do with someone who's obese, it's a lot harder. So yeah, fantasy, take out the organs, put them back in to get down to because most of the major arteries, at least, are in the deep part of the belly and the chest. And so getting access to them can sometimes be a large part of the case.
What is one of the biggest things that have changed in medicine from when you started out to today, and where do you think medicine is going to go in the next 20 years?
Yeah, so I think one area in medicine that's really revolutionized things is medicines that have decreased inflammation and cholesterol. So the statins have markedly impacted the patients I see, because they're patients with coronary heart disease, for which it primarily treats, but it also treats peripheral vascular disease. They're living longer, and it's been a great advance. Technologically, the biggest change that I've seen is the ability to, again, fix aneurysms or arteries from the inside out. So the endoluminal or endovascular technology has exploded and really changed the way vascular surgeons and interventional radiologists and cardiologists practice. So that's really been over 25 years. So pretty rapid. I think the things going forward, everyone sees them on the news, and the GLP-1 agonists. So again, ability to decrease not only obesity, but that impacts their heart disease and their kidney disease. So that's going to be the next revolutionary area. I think they're going to have further, modifications of those medicines to make them more tolerable, so people don't have so much nausea.
Excellent. Do surgeons listen to music in the OR?
Oh, yeah.
And if so, what do you listen to?
Hip hop barbecue.
Okay, very nice. What are, you said, surgery is a team sport. What are some of the other teams in play that you sort of work with as a surgeon?
Yeah, so, we have our trainee teams, students and residents and fellows really do the day-to-day and all the really hard work in taking care of our patients. But really also within that is our nursing team. So at least here, we have a really good working relationship with the folks on in this case, it's on our 5th floor, who take excellent care of our vascular patients. Our clinic nurses are advanced practice providers who see the patients often first or in follow-up. And we have our sonographers who do the ultrasound studies that vascular surgery relies on. And then just our administrative help in the office, to keep our appointments, make sure we're not, that we're renewing our licenses and all those little things. So it's really a super big team sport.
Excellent. My final question: what has been the most memorable moment of your career as a physician?
From an academic standpoint, I would say getting past the first, big bar from going to assistant to associate professor. You have to have grants and papers and all this type of thing. So that was pretty fulfilling to be able to pass that bar. And then going from associate to full professor is a medium big deal, but it's not as high a bar to cross. So I was happy to be able to do that. And again, that's kind of the academic fulfillment. But I think, personal fulfillment is not one, but when you see your patients back who've been through a tough course and then they look pretty good or they're doing well, that I think is, for most surgeons and physicians, actually what keeps us, what makes us such a satisfying career.
Excellent. Dr. Henke, thank you so much for your time.
Thanks
really
for asking.
Appreciate you.
Yeah.
All right. Should be good.